Thank you, sir.
So, friends, today we have a topic on psychosocial issues and school management type 1 diabetes. Okay, we have Dr. Saptarshi Bhattacharya as our esteemed speaker, esteemed faculty. We have Dr. Alok Bhandari, President of Indian Academy of Trades, Delhi State. Dr. Ajay Gupta, he is past Secretary of IAP Delhi, President and EB member of IAP twice. And we have Dr. Utkarsh Sharma. Dr. Utkarsh is Executive Board member of Central IAP from Uttarakhand. And it's also, I'm very fortunate to have worked under Dr. Utkarsh Sharma. He is my current senior from Meerut Medical College. And I always received his love and affection. And we have Dr. Rajiv Singla also there as moderating today's session. Friends, as we all know that type 1 diabetes not only affects children physically, but it also affects them emotionally, socially, and there are a lot of intricacies and complexity involved, not only for the children, but also for their families. And everyone who is having some kind of chronic disease will all have some psychosocial impact on their life, including the patient as well as on the caregiver and the family around. So today we have Dr. Saptarshi Bhattacharya. He'll be guiding us on various psychosocial issues and their management in type 1 diabetes. So, and we also have acknowledge the presence of Dr. Vipul Jain. So over to Dr. Rajiv Singla, and Dr. Rajiv, I would request Dr. Rajiv Singla to kindly introduce Dr. Bhattacharya and moderate the session.
Yeah, so good morning, everybody. I think what we've done so far in this course is that we looked at intricacies of insulin therapy, carb counting, diet, how to match your diet and the insulin dose together. I think with this today's session, we are going looking at other important issues apart from just looking at their blood glucose values, insulin doses, and everything, because these factors, I believe, are even more important because these are unique to each child. And then unless we give them a solution which is suited to their needs, suited to their family needs, then generally it does not lead to a good result or outcome. And nobody can be better than Saptarshi Bhattacharya to speak on this topic. He's a very, very dear friend. We go long back, more than a decade together. He is one of the most prolific orator and a treat to listen to always. He's got innumerable number of publications to his account, and then he's, I think, at the moment, I believe you are looking at a future president of Endocrine Society of India. So over to you, Rishi.
Thank you, Dr. Rajiv, for the kind introduction.
Dr. Saptarshi, sorry to interrupt you. Our guest chairperson today, Dr. Utkarsh, is busy with an exam, so I would request him to give his opening remarks or comments on the topic before he gets busy. Dr. Utkarsh, please boliye, sir.
Thank you, Dr. Alok. I would like to acknowledge this as a very crucial and need of the hour. Nowadays, it is like an epidemic situation that most of, because of the advent of newer modalities of diagnosis and better care, we are able to diagnose early, we are able to manage better, as we have already seen different modalities, carb counting and glucose monitoring and all that. But this issue is always neglected when we discuss all these things. And I would like to acknowledge Dr. Saptarshi Bhattacharya is the best person among our all endocrine domain to give the how to deal with these issues, because they are ultimately the outcome is dependent on how you are dealing with the supportive care or the issues which are related to psychosocial or emotional aspects of the caregiver or the patient or the family or the school Even few schools are very friendly nowadays. CBSE has also introduced that they will allow sugar and all these things when in the exams, and also insulin pens are also available. So I would like to acknowledge we all should contribute how we can improve their psychosocial aspects. And I would love to listen Dr. Saptarshi Bhattacharya. And now with this, I would like to invite him for commencing the session. Thank you, sir.
Thank you, Dr. Utkarsh. Thank you, Dr. Rajiv, for the kind introduction. And thank you, IEAP, for uh, associating with speed and bringing all these very important topics to forefront. So we keep on discussing as we have been talking about management of diabetes, but this is psychosocial issues is something which often gets neglected. And why it's important is that obviously psychosocial issues are needed for the well-being and holistic development of the child. If that is lacking, so that is a very integral part, and directly or indirectly it has a link to adherence and even medical outcomes. So obviously we have multiple studies which suggest that psychosocial issues are linked to adherence and in turn linked to HbA1c. So they have an impact on both the well-being and the development of the child, as well as the adherence to outcome and the glycemic control and other related complications. So if we look into lack of non-adherence in adolescents, so I won't go into this part in details. Just to start, I will start with this, but I will mostly be shifting to psychosocial issues only. So if this was a study which was done back almost 15 years or so, so cognition, perception of ailment, psychological factors, patient education, family functioning, complexity of therapy, and interference of the treatment in patient's lifestyle. So this is where we are looking into an adolescent child, but so where the psychosocial issues actually, as we can see, they're all it's a bidirectional or multi-faceted relationship where you can't dissect out one from the other. So both are very intricately linked, and as we said that adherence and glycemic control and complications are related to it, but also important are psychosocial issues as a unique entity, because they are related to barriers in type 1 diabetes care. They have an impact on the family, they have an impact on the child. When we are dealing with psychosocial issues, the children growing up, when we need to know when we need to let go and hand over responsibilities. So this is something which is also equally important. The transition to from a child care to an adolescent care to an adult care, that also has an impact. And obviously we'll be discussing the school part as well. And overall, we need to create a safety framework which is best suited for the child. If we look into the barriers in type 1 diabetes care, I think we have been discussing it over the last 5-6 episodes. So obviously lack of acceptance, social stigma, lack of knowledge. In our setup, lack of access to resources and financial constraints also do play sorry, a major role in as a barrier to type 1 diabetes care. So, but sometimes we have a child, the mother and the father are totally awestruck. Somebody comes to our OPD, the fasting glucose is in the range of 400, 300, 200, HbA1c of 10, 11, 12, 13. So the family doesn't know what to do with it. So the first thing is that the acceptance and the social stigma related to type 1 diabetes, so that plays a very major role. So obviously that requires a lot of discussion, lot of counseling from the doctors. Maybe if you have a support staff who is a specialist in this, also that part we have diabetes educators in our team, so they also play a role. And during the counseling process, obviously, what we need to make them understand, it's difficult from type. It's a difficult situation, and it's different from type 2 diabetes, where some lifestyle factors do play a role. In type 1 diabetes, obviously, we know it's an autoimmune condition, so there can be like genetic factors, epigenetic factors, some known and unknown environmental factors, and again immunological factors. So we still do not have an answer. So if the uh, parents ask why my child develop type 1 diabetes, sorry, so you can't give an answer. So we know that uh, what we can tell them is that there are no known reasons which you could have avoided, that could have avoided the development of type 1 diabetes. So this is not in our hand. So there are obviously, as we are discussing, genetic factors like HLA, insulin variation, CTLA4, other genetic associations are also there. And but again, as we all know, that this is not and entirely in our hands. So we need to tell, sometimes the blame is always put on the mother, that this has happened because of your fault, or somebody was having gestational diabetes, whether type 1 development of type 1 diabetes is related to that. So that is actually, there are very little data to support that. So what we need to tell the parents is that need to reassure them, need to tell them that this is nobody's fault, and also simultaneously start the process of managing type 1 diabetes. So there is an impact of the family on the child. So it's very, very important that the child should have a receptive family who does not blame the child for this. So that is the worst part that can happen. So it's a hard situation for the child. Maybe it's harder for the parents, but uh, how the attitude develops. So it's a complex situation where the family, the child, the school, the other caregivers, other associations, maybe his friends, siblings. So everybody has to taken into confidence, and they need some sort of counseling to make them understand how they should be behaving with the child. And also we need to understand the parents also go through a very significant trauma. So all counseling processes should take into consideration that part as well. So, and on the other hand, there is the impact of the child on the family. The family also feels that our lifestyle has totally changed. So their thought process will be revolving around whether the child developed hypoglycemia at night. So mother will always be alert. So maybe will start losing her sleep. If the child is going to the school, the parents will keep on thinking whether he will develop an hypoglycemia in the school suddenly. If the child is going to play, so that also will be in the back of their mind. So there's a very significant amount of underlying anxiety which will be there, and the thought process of the parents require counseling. So it's a shared responsibility which we need to take into consideration, and fault finding should be strictly avoided within and without. So that is very, very important. So also very important is how the sibling is behaving. So if you have a very differential behavior to the child with type 1 diabetes versus the other sibling, so that can also have a negative impact on the child, on the sibling, as well as on the overall family. So so these are steps, there are ways to deal with it, and we'll go into some of the guidelines which have been recently advocated. And but this is one area which, thanks to Dr. Rajiv for bringing this up in this series of discussion on type 1 diabetes, which is often ignored, and we need to focus on it more and more, because it's not only important for overall management of type 1 diabetes, but also overall development of the child. So there are again situations in type 1 diabetes. So it's a phase. There are lots of steps into it. So maybe the child develops type 1 diabetes at the age of 5 or 6 years. When the child grows up, obviously he will be given more and more responsibilities to deal with related to type 1 diabetes. So we also need to know and also need to counsel at what particular point of time the child can uh, get more and more involved in his or her type 1 diabetes management, and the parents also need to go. So this is important to develop a sense of self confidence in the child himself or herself, but also required for uh, required for better type 1 diabetes management, because ultimately he is the one who has to deal with all these problems. So unless he becomes more responsible, then that the parents can't keep on taking care of the child's diabetes forever. So there are milestones like self testing, self injecting, deciding about food, deciding about doses of insulin. So this all comes step by step. So and there are again no particular cut points that this is the time this should be done. Depends and varies from child to child, the development and the understanding of the child, the understanding of the family. But these are milestones where there is a need for transition, and that has to be incorporated in the management of type 1 diabetes. So this was the 2022 ISPAD clinical practice consensus guidelines. So there are broad 5 headings. So foremost among them was collaborative care. So we often ignore psychosocial care as a integral part of type 1 diabetes management. So professionals with expertise in mental health of children and adolescents should be part of the team. So this is what the ISPAT says. Sometimes it may be difficult in our practice because there are financial issues, there are other issues, availability issues, but this should be there. So maybe in our setup we do a we go beyond what just about deciding the dose of insulin and deciding the monitoring frequency and deciding about carb and insulin ratios. So so this all even if we are not ideally actively going into the psychosocial care of it, but we should have a very clear understanding that at what when in a particular child we need to involve a professional who has this development. Ideally it should be for all children. With our resource constraints and limitation, we need to take that call that this child or this family or this mother will require a psychosocial care and assessment. And so it's important that collaborative care becomes part of management of type 1 diabetes whenever it's necessary. The step 2 is integrating psychosocial assessment in routine diabetes care. So there are various psychosocial assessment tools. So again, not very commonly used in our practice, but the ISPAD uh, does recommend that we need to bring it in, maybe put in some sort of structure. So there are various tools, there are comprehensive tools, smaller tools. They assess overall psychosocial well-being. There are assessment tools for quality of life. So again, there are tools depending on the stages of life, from children to adolescents or adults. So some sort of screening for depression, diabetes, distress, disorder eating, especially in children aged 12 and above, and use validated tools. So difficult in maybe in our day-to-day practice to incorporate, but if we can put a structure, so that will, so maybe in high volume centers where Rajiv is treating, he has a huge number of type 1 diabetes children under his follow-up. So all this should be maybe if we can integrate this aspect into type 1 diabetes management, so that will be helpful for the children as well as the family. So the cognitive capacity, school functioning, all this should be integrated. And even if a child is having evidence of diabetic ketoacidosis. So many of the time, the cause is not actually medical, but it's psychosocial. So there were some anxiety issues going on, there were some depressive issues going on, there was some distress which was going on, and that is the reason actually the parents or the child stop taking insulin. So we usually will, when somebody comes with diabetic ketoacidosis, we try to find out the cause, whether we're missing out any infection or some other intercurrent illness. But I think what we often do tend to ignore is the psychosocial impact on these outcomes. So that is something we need to understand. Even there are cases of recurrent severe hypoglycemia. So there can be cases where the child for some reason is injecting higher dose of insulin to precipitate a hypoglycemia. He can, so that he or she can eat sweets. So these things do happen in type 1 diabetes children. So we all know from our experience that these are not uncommon. So unless we have a system, we have a process where we can integrate these aspects into the management of type 1 diabetes, so we won't be able to prevent them. So maybe if somebody does it, we and if we are aware, then we can deal with it. Sometimes we might miss it also, but if there is a system which can be individualized to according to our practice, our patient load, so that will definitely help in avoiding many of these complications. Now, if we look into diabetes management aspects, so psychosocial care and diabetes management, they are very closely interrelated. So if you are not understanding the psychosocial status of a family or a child, and you are giving the most advanced insulin regimen, where maybe you have asked to check 7 or 10 times in a day, but they might not be having the financial resources, or they might not be having the motivation. So if these two things are cannot be integrated, so that becomes a challenge. So you will again never get the desired outcome in these situations. And also, what is also important is to, if you are dealing with diabetes management, you at each and every step, you need to assess the understanding of the child about diabetes related knowledge. So whether the child is able to understand what the insulin adjustment logic should be, what are the required goals if somebody develops fever, so whether they can understand the sick day rule, how much autonomy should be given to a particular child for self management. So again, during transition, so if you give more, so there can be problems. If you give less, the child might be underconfident, that can also be problem. So this is a continuous process where like we take an assessment of HbA1c and other complications in the routine visits to our clinic. Also, we need to have a routine understanding of the assessment power, or the skill, or the knowledge of the person living with diabetes to deal with these problems. And when we are making treatment recommendations, providers should consider the perceived burden and self-efficacy and level of social and family support. So what I was telling just now, that if these are present, and we are going for a very advanced and complicated diabetes management, so they won't go together hand in hand. So these two have to be integrated. The level, the way you are managing diabetes, obviously the more aggressive we get, or the reasonably aggressive we get, we will get better results. We know the more we have values from about SMBG, so the results are going to be better. But again, this has to be taken into the motivation and the understanding and the socioeconomic status, all have to be taken into consideration when we are talking about psychosocial issues in type 1 diabetes. The next point in the recommendation was diabetes in context. So it has to be an interdisciplinary team. So, and a general family functioning, including stress, conflict, cohesion, adaptability, parental psychopathology, diabetes related functioning, especially during periods of transition, and whenever you are suspecting that there can be a family or culturally based difficulty. So there are grandparents who sometimes feel that this is now not whatever the doctor is telling is all wrong, and so this is all not required. So we have this intervention. So all these things should actually figure in our diabetes management. Whenever you feel that referral to a proper mental health professional is required, that should be done. Again, as we have discussed, that we should be developing a process where there is a mutually agreed discussion that about parental involvement, support, self-management. So all these things have to be incorporated. So we should be authoritative, responsive, respectable, and also autonomy of supportive communication should be encouraged. So these are important aspects which we need to look into. And about the demands, expectations, burden. So this is complex, as we have been telling, but this is time consuming. So that is why where facilities are available, they are they are recommending that we should be in encouraging the role of a dedicated mental health professional. It's not always we will be looking at the HbA1c, at the SMBG values or the CGMS values. We will be looking into the complications. But again, the amount of time this requires. So there are support groups which are coming on. There are apps which are coming on, which are all helping the mental health professionals who are actively dealing with it. And obviously, diabetes technology will play a role. It's playing in all other aspects of diabetes. So if you're looking into the psychosocial aspect, so wherever you can use technology, that should also be included. And finally, there are interventions which are required in certain children. So this intervention should emphasize appropriate family involvement and support in diabetes management. Also, there should be evidence-based psychosocial behavioral or psychiatric intervention. So not everybody will be requiring it, but you need to take a call when this is required. Very, very important for psychosocial management of type 1 diabetes. So to summarize the first part of my talk, which was the psychosocial aspect of type 1 diabetes. So type 1 diabetes obviously should not limit any child's potential to reach his or her life target. It should be incorporated in management of type 1 diabetes. For high volume centers, considering Indian situation, a dedicated mental health professional will help. Where these facilities are not available, you need to be more sensitive and open to discuss, understand, and refer whenever it's required. And if we now move on to the school aspect of diabetes, so that is we had comments from our chairpersons and Dr. Rajiv that all this there has been a significant shift in our understanding of management of diabetes in school. So 10 years back, it was really difficult. So there were some schools which were even not accepting children with type 1 diabetes, and there were no rules whether the child could take in sugar or glucose monitoring devices. So everything was very, very confusing. Thankfully, things have evolved. So we are moving in the right direction. So the CBSE has allowed snacking during exam for children with type 1 diabetes. So there are again some steps in managing schools in type 1 diabetes. One part is how the school and the parents should and the child should be working together for optimum outcome during the presence of the related to glycemia and other aspects as well when the child is in the school. Also, it's important that the school timing might not always match the insulin profile. So it's a challenge we all face. So if a child is going to school in the morning, most of the children will be having a glass of milk and going, not eating a proper breakfast, and they will be having their snack with all other children or their breakfast or with all other children in the school. So that mismatch, how we can deal with it, also is a very important aspect of managing diabetes in school. In maybe not very relevant in Western countries where most of these children will be having access to insulin pumps, but uh, managing subcutaneous insulin before and during school hours is a challenge we all face. We know that that this is something which we need to specifically look into, specifically ask the children and the parents with type 1 diabetes, that what is your school hours, when does your, what is the distance, when does the school bus come, when do you have your snack. So if so this is very, very, very important, because if you have those 7 8 hours of hyperglycemia or hypoglycemia, so that is actually going to affect the overall diabetes management. So maybe the child might be doing very well throughout the day, but apart from those particular 6 7 hours, and that can actually affect the diabetes overall outcome and HbA1c for many of these children. So if we are looking into the school part, so we need to look into whether the child can carry a blood glucose monitoring device. Again, will depend on whether the child is able to do it properly at home, then only obviously he can carry. Insulin administration, how is going to take the insulin, how is going to carry the insulin, where he is going to inject his insulin, if he is planning to do it in the school, what meals and snacks should be given. If there are symptoms of hypoglycemia, then what the child should be doing in the school. If there is symptoms and treatment, symptoms of hyperglycemia, somebody is having, say, started having vomiting at school, you're suspecting DK. So all those things also should be incorporated in the school specific management of type 1 diabetes. Testing for ketones, participation in physical activities. You cannot, so on all the other children are playing, you cannot deny the child that okay, you sit back home or sit back just because you are having type 1 diabetes. And if in case there is a major emergency, how, what should be the contact point, how to handle it. So all these are actually very, very important if we are looking into school management of diabetes during school hours. So there are some responsibilities from the part of the parent. So all materials like meters, test strips, lancets, the lancing devices, insulin pumps, backup syringes, if there are other medications necessary. So they should be ideally even some glucagon emergency kit. So the shelf life is going to be a problem with that. So they should at least figure and how the child is going to take all this into school, whether the child is going to inject or not, whether how many times the child is going to monitor during the school, what he will go through mentally if he's monitoring too many times, what his friends will think. So again, a very complex area, but this is an inevitable aspect of all school going children with of type 1 diabetes, and we need to actually discuss all of them. We should have a proper treatment plan, as already discussed. We should have a emergency contact number for parents and care team, food plan, and confidentiality release when the child can discuss. So the treatment plan should also be communicated with the teachers. At least there should be one teacher who is one or two teacher, and the healthcare team ideally in the school who should be responsible. And you can even write the dose to be given during each tiffin for the children who are taking insulin at home, at school. So there are some responsibilities of school as well. They should be being, if the school is not being receptive to a type 1 diabetes uh, uh, child, so obviously there is a lot that is being demanded from there. So that should be, we should create more awareness about type 1 diabetes, and we that should be part of I think IAP, and is obviously already acting very actively in this aspect. We need to reach out to schools more often, and maybe create some sort of education program for even for school teachers or so, for that, for type 1 diabetes children who are attending the school. So some of the school staff should be capable of medical care or managing a hypoglycemia situation, or so this again should get incorporated in school staff training. A child should have an immediate access to treatment of hypoglycemia. So if the child suddenly starts behaving abnormally, so that teachers should be aware that there can be a period of hypoglycemia. So all this can be very easily done. It just requires awareness, little bit of education and some acceptance and for of the overall society, for the even his school, some of his for a slightly older child, his friends also can be taken into this management scheme, and can be involved in the process. So if we now look into a clinical scenario, so of we are discussing the social responsibility of the school, responsibilities of the parents, the child, what he should be doing in the school. But what happens in many of our clinical day-to-day practices, that the child, what we were discussing, that the child goes to school after having a light, maybe a glass of milk and a biscuit, then will have bulk of his meal, breakfast, or in the school. So this child, 10-year-old, A1C 8.2, is on Lispro 6, 12, and 8, and Degludex 16, and some adjustment according to the blood glucose. The fasting blood sugar is 131, but when the child comes back from the school, it's usually in the range of 300. So the correctional insulin is being given. It comes down after lunch, stabilizes to around 180, 190 before dinner. So this is something which is very, very common in many of our children who are going to school with type 1 diabetes. So this is approximately how the child takes his morning snack and food. So there's a glass of milk and one bread piece to start with. It takes a lower dose of insulin, is not injecting any insulin during his fruit break and proper breakfast, comes back with a blood sugar of 300 every day. So so many of our children this is one of Rajiv's patient who had. So if you look, the fasting is 149, 159, 124, but at when the child is coming back, it's 343, 294, 295. And again, you are giving a correction and insulin is coming down. But this will actually cause the HbA1c to go up. So how can we deal with it? So if the best situation will be the child is on a pump, but obviously that has financial limitations, and majority of our children will not be on an insulin pump. So we need to adjust either. So there are three things we need to adjust. One, the insulin dose. Number two, the food. Number three, the activity. So these are the things. There is no golden rule. Okay, this is the answer for this situation. So it's a question of titration, monitoring, adjustment, and readjustment. So the options we do sometimes use is instead of giving an analog insulin, we sometimes give a regular insulin, which has a slightly longer delayed peak and a longer duration of action, might cover till before lunch in some cases. There are some situations, so you won't get too much of current literature related to this in most of in the articles, because this is not something most of the children in Western world actually have transitioned to insulin pumps. This is a situation which is very, very unique to India. Sometimes we actually do give NPH insulin and try to. So again, it has a delayed peak. And though theoretically, if you cannot combine two different long-acting insulin in the same person, but these adjustments and readjustments are sometimes required for having an optimum outcome in terms of glycemic control till lunch. Sometimes even premixed has been advocated. The other options can be if the child, the best option will be child takes a small dose before going to school and carries the insulin to school, takes a proper dose during the proper breakfast, and that will most probably the number of pricks will go up, doses will go up to 4. But that in our situation, that might be the best and most scientific way to do it. If the child is actually having problem in injecting insulin in the school, we might try all these tweakings. Sometimes what we do is we ask the patient to shift the major meal to early morning. So we try to reinforce and educate the parents and the child that if you are not ready to inject insulin, the first meal should be taken, the major meal should be taken when you are injecting insulin, and the child can have a light snack, maybe a protein-based snack during the tiffin hours. So that is another option if the child is not actually ready to inject insulin. But in an ideal situation, maybe pump is the best solution. Number two, a second dose of insulin. Number three, maybe readjusting the meal. Number four, if all this does not work, you can try out an NPH or regular, sometimes a premixed insulin. But again, theoretically, that does not always fit in. But it's there is no one golden rule for this particular situation. So we know all this is the insulin profile of the standard insulins which are available. So it might match the school and the timings and the food the child is taking. It might not match. So we need to do this juggling in this particular situation a little bit. So these are the diabetes UK recommendations for managing type 1 diabetes in school. Most of these are actually again applicable to our children with type 1 diabetes in India as well. No child with diabetes should be excluded from any part of the school curriculum. So that is very, very, very important. And they should be taking part in all extracurricular activities. The school, local authorities, health services, in these cases, the school, the parents, and the providing healthcare provider, they should work together. Pediatric diabetes team should provide training and support to school. So this is where area maybe we have already started working, and maybe we can even do more to train the school staff and the school healthcare teams for required skill of type 1 diabetes management. And it's not possible for a parent actually to go to school to treat the child or to inject the child. So there has to be a way to do it. So again, that is very, very important, that how we are managing diabetes in the school. There should be some support from the school so that the child feels comfortable and does not depend his or her parents to go to school to manage hypoglycemia or to inject insulin. So very there's a UK guideline, but most of this will be applicable to our children also. All children should be allowed to inject insulin in public or private, depending on their choices. So these are again important things which we need to incorporate. Every school should have a medical condition at school policy, and every child should have a clear-cut individual healthcare plan. Preferably should be discussed with the class teacher, some of his friends when they go, if the friends can take care of. Up-to-date information about the child's diabetes needs should be shared with the school. And again, as we discussed, that there is no one rule that will fit all. So every child will have different needs. School staff should be able to deal with cases of emergency. Schools and parents should agree on a clear method of communication, who should be responsible, who should be the contact person. And if somebody develops hypoglycemia, the child should never be left alone. The child should never be prevented from blood testing or taking insulin, and should be able to look after their equipment themselves. They should be having specific plan and should not be sent home frequently or penalized for poor adherence when absence is related to their diabetes. So very, very simple things, but very, very applicable. Most of these things are very, very applicable to each and every child with diabetes to make him or her comfortable at school. So I would end here. So obviously there is a where there is a will, there is a way, there is a lot to go. So we are moving ahead, but again, there is a lot which is needed, especially if we are looking into psychosocial aspect of diabetes management as well as school management of diabetes. Thank you. I hand it over back to the chairpersons and IAP team.
Yeah, I think that was a very, very crisp and clear message. I think we looked at three different aspects, starting from the psychosocial issues and then going on to what are the responsibilities of parents and the school in creating those resources, and then finally how to actually practically manage these children when they trying to manage their glycemic control in the school itself. So Rishi, please all of you go ahead and send your questions in Q&A box so that we can take that up live. So Rishi, while few questions are coming up, I just want to kind of take your call or take your view on the fact that sometimes what I struggle with is two special family members. One is the siblings, and then another are the grandparents.
Right. Absolutely.
So the problem, I know that there may not be a right answer, but thing here is that parents always come back and say that there is a younger brother or younger sister. So now you don't have to give. आप इनको शुगर नहीं दे सकते हैं, but how do you handle the sibling? उसको शुगर देते हैं तो इसको नहीं देते हैं. There is a discrimination. So it's a I don't know whether it's a moral dilemma, it's a practical dilemma or what, but I have not been able to find a solution to it.
I think, Rajiv, it's a very practical problem we all face. That if a child is having diabetes and maybe is not able to take chocolates or sweets on a very regular basis, whether the sibling in front of that child can actually do that. So we don't have one right answer. So it depends on the sibling also, it depends on the family also, it depends on the child's understanding also. So it's a dynamic thing. So we need to discuss, understand each and everybody's mentality. So how what impact it has on the child, so that has to be taken into consideration. What impact is it's having on the sibling, that also has to be taken into consideration. And what roles the parents are playing to make the two siblings understand the importance of the overall situation. That also, that is a third aspect which is which is taking into consider, which has to be taken into consideration. So I think all these three things put together, we need to strike a balance, a way out where we need to follow a moderate way where maybe everybody is happy in this situation, but again, a very difficult situation to actually deal with in practice.
Right. Yeah. So another thing is that when kind of dealing with kind of deciding dose or kind of managing these values at in the school, I think sometimes what I tend to do is that I ask them if we can really give them a very low carb snacks or maybe non-carb snacks during the lunch time. So sometimes that does help. We actually shared a list of
Absolutely.
kind of these snacks in the group itself. So sometimes in few patients that help, but again and again I just want to emphasize that this barrier I consider as a barrier similar to multiple subcutaneous injections. We had struggled in the past in shifting people from pre-mix to multiple bolus injections, but I think I now believe is by and large have crossed that path. So now most of the children who even come from reference from outside, they generally are now on 4 injections. Hardly any of them I see now on a pre-mix injections now. But I think this again is same thing. As a caregivers, as doctors, we should persist with what is best standard of care, and then we should force schools and kind of sensitize parents to ensure that this is not acceptable, that somebody is not injecting them at school, somebody is not allowed a safe environment in school is not acceptable. Sometimes when parents say that we are not able to, we are not sure how schools are going to, I always tell them that go back and make them talk to me. And believe me, nobody has called me back ever, because just that courage and the support at the back, that there is somebody who's going to talk on behalf of us. Most of the children has been able to talk to school, and then schools have been pretty receptive about it. So I think it's again just an understanding issue, just a hesitation issue, an inertia issue. And if all of us persist, then I think most of the schools and parents are going to accept that.
Absolutely. So I also agree with that majority of my children of type 1 diabetes will be either on on a light meal with a light dose of insulin to start with, a protein-based meal in the meal time, and the sugars are reasonably okay. Maybe not in the range of say 120, 130, but not again in the range of 250, 300 or 350 when the child comes back. But again, if we are not following that, the other option is, which is a better option, will be a light dose before the child goes with a light snack if he's not able to take a full meal. We need to sensitize school. So there have been improvements. So we were earlier there was even a barrier to giving sugar during or glucose during hypoglycemia in school. So that has improved. So again, we need to work on this aspect in the school as well, that there is a need to inject a insulin during the meal timing in the school. So that should be, I think, the next step to go ahead in school. So there is a need to sensitize that among the schools and the teachers. I think that is something which is important.
Yeah, absolutely. Absolutely. I think there is only the question on the chat box is how to calculate dose of NPH and regular insulin. I think we have had a detailed discussion in the previous sessions on this. I think the dose of NPH, only thing that we can comment on this in context to the previous sessions is that the dose of NPH is calculated as a basal dose is calculated. And then I think the IAP would provide the videos of previous sessions. So if that is not clear, I think we need to go look at.
We already circulated all the videos of previous 7 sessions. We will still once more circulated for the benefit of all. So we have Dr. Anurag Agarwal here, past president IAP Delhi. Dr. Anurag, are you here?
Yeah, I was listening to the interesting discussion going on. And it's really nice that you have such a lovely module and such excellent speakers. Thank you.
So I hope there are no more questions. I think today everybody is more interested in the clinical management rather than the psychosocial management. So we have, but this is an important part, very complex issue, and I'm really thankful to Dr. Bhattacharya for making this talk simple, lucid, and inspiring. And I hope everybody benefit from today's session. Dr. Bhandari and Dr. Utkarsh, if you are able to give your closing remarks.
Hello. Good morning, Dr. Bhandari. And I would like to say that there are few things in my mind which I just want to say. Rather than making this a stigma that a child should not take candy or sugars, carb counting, and if we give some extra bolus dose of insulin, because as this issue is a very crucial emotional aspect also with grandparents and even kid also. So I think rather than making a stigma that this child is hesitant of taking all these things out of his list of eatable items, I think it is better because that creates more craving in that child and agony in the parents. I don't know how do you see to this aspect, but if parents are sensitive enough and they are legitimately counting the carbs and all that, so I think that would be a one way how we can pinch out this thing. Otherwise, I think school education and implementation of all these things in school is an important aspect which IAP should take as a stance, and incorporation of government policies to sensitize that teachers should also be trained in glucose monitoring and hypo and hyperglycemia management and all that. And I would like to acknowledge that although Dr. Bhattacharya has explored all the touch upon all the points related to psychosocial issues, and I learned a lot of things. And I wish that we all in future also we keep learning with such kind of sessions. Thank you very much.
Thank you, Dr. Utkarsh. Thank you so much for attending this session from Uttarakhand. Thank you so much, sir. Thank you so much.
Thank you. Thank you.
So, on behalf of Indian Academy of Pediatrics Delhi and on behalf of SPEED, who are academic partners for this module, I am really thankful to all the office bearer of SPEED and the esteemed faculty from SPEED. Special thank you to Dr. Rajiv Singla for making this module success. And so I would finally thank Dr. Saptarshi Bhattacharya for today's excellent session. Thank you so much, sir. We are indebted to you. Dr. Rajiv Singla, Dr. Utkarsh Sharma, Dr. Alok Bhandari, and Dr. Vipuljan, thank you so much. We acknowledge your hard work and appreciate your efforts for making this module a very successful one. And I am also thankful to all the delegates who have attended today's session. Without you, all these academics are not going to be successful. So thank you so much. And over to you, Dr. Rajiv, for last closing remarks.
Yes, sir. I think first of all, I must thank you most of all and Dr. Bhandari for kind of allowing us the platform to make this all of these modules happen. And I think we've seen a tremendous response so far in this session. And then this one single platform has I believe has given a great support to type 1 diabetes education in our country. So thank you to both of you. And to Dr. Vipuljan. And to Dr. Vipul.
Dr. Vipul, thank you. Thank you, everyone. Thank you.
Thank you, boss. Bye.